skull-base surgery has evolved over the last 20 years from being a very invasive type of surgery to get to a very difficult place to something that's become much more minimally invasive and much better tolerated, and show some of the data I produced to try to support that whole effort. So I'm going to start talking a little bit about the history of skull-base surgery. And as is all known, this famous saying by George Santayana, those who do not remember the past are condemned to repeat it. So it is important to take a quick look back before we look at where we are now and try to figure out where we're going. Another great quote, telling the future by looking at the past assumes that conditions remain constant. This is like driving a car by looking in the rear view mirror. So things are always changing, and our field of neurosurgery is constantly changing. And I think this talk will give a bit of an overview showing how it's changed. We like to think that we're fairly far along in our evolution, although we're probably back here. At least I hope we're back here, and I think we have a long way to go. But the good news is we're probably not at the beginning of our evolution. So I'm going to talk today about skull-base surgery. So what is skull-base surgery? It's traditionally been one of the most difficult areas to access surgically. The skull base is surrounded by several critically important nerves and artery. And in order to get there through a craniotomy, requires significant retraction of the brain or incisions in the face. And it has in the past been very highly morbid. So this is obviously the cortex, the skull top, as we would say, or this is the top of the cranium. When you remove the brain, you get to the skull base. And as you can imagine, it's a hard place to get to because it's protected by the brain and by all the facial structures. So that's the skull base. When we look at it in the sagittal plane, it's this area here that is the skull base. Now, traditionally, and this is how I was taught, we would get there by doing a craniotomy. And a craniotomy involves moving the brain out of the way. And you can get retraction injury to the brain when you do that. So about 30, 40 years ago, people collaborated with ENT surgeons and head and neck surgeons to develop these complex approaches to try to remove a lot of bone to get to the skull base rather than retracting the brain. And these are just some examples of some of the approaches that try to get us to the skull base. But what you see is that they're better at exposing the nerves and the arteries than the actual skull base. And often the pathology lies behind those structures. So these approaches, while great, often cause a lot of morbidity. Big incisions are required, often in the face. There's a lot of removal of bone to try to avoid brain retraction, but nevertheless, you still have to retract the brain significantly. This shows frontal lobe retraction. These openings often require complex cosmetic closures to prevent CSF leak and are pretty disfiguring and morbid. This is a maxillary Lefort osteotomy that's done to go in through the mouth in order to get to a place where we can get to very easily with what I'll show you, which is an endoscopic skull base approach. And because a microscope was used for illumination in these surgeries, a lot of retractors were also used to create an opening. This is an opening in the mouth to try to get where we need to get. So there was an approach that's similar to what we do now, but it had limited exposure, and that was what we call the transsphenoidal approach, and involved a sublabial incision below the lip, and then you'd put a retractor in on either side of the nasal septum, but because you were using a microscope, you really couldn't see that much, and you had a long septum called a Hardy retractor that limited your field of view. Now, the idea was to replace this craniotomy that requires brain retraction to get to the skull base from above and try to basically flip everything over because the nerves and the arteries get in your way. And by using this transsphenoidal approach, but modifying it so that we only use your nostrils to get in, we could open up the sinuses, which are mostly air-filled, and expose the entire base of the skull. And then by drilling out some bone, we could basically approach these tumors from the underside, in which case you get to the tumor first and you get to the arteries and the nerves afterwards. So that just shows you the tumor being removed. So the history of the transsphenoidal approach dates back to the 1800s, 1900s, where surgeons would first go in through the glabella, which is the bottom of the forehead, make an incision there to try to get in through the nose. This guy named Herbert Schlaffer in early 1900s developed another approach where he would literally flip the entire nose off to the side in order to get where he wanted to get. But the transfrontal approach that I showed you with the speculum was developed first by Coker, Hirsch, and then Cushing, Hardy, and Guillot. Cushing actually used it and then abandoned it in order to try to minimize the damage to the brain and the face. But the key was the introduction of this, which is an endoscope. The advantage of the endoscope is it has its illumination and also its lenses at the very end of the tip. And by advancing the tip in, you could see much better. So the microscope on the left has its lens and light source at the back of the narrow tube, which would be the Hardy retractor. So you only see a little bit of Mr. Tumor's head. But if you put an endoscope through the nose, you then get your lens and your light source at the tip, and you can look around and you can see much better. So this is the concept, using an endoscope to go through the sinuses to get to the skull base. And this is what it looks like when we do our surgeries, and you can see how minimally disruptive this is compared to the approaches that have been used in the past. And this is the view of the entire skull base with an endoscope. You can really see everything, and you can see it from a completely different angle. So the endoscope also has a bit of a history that I can talk about, and it starts out with just the speculum, which we know well and is still used to get into some orifices and cavities today. This is just an ancient Roman speculum, but this guy named Bozzini invented something called a Lichtleiter, or a light conductor, in 1804, where he would advance a light into a cavity. It was basically a candle with a mirror and a funnel-shaped tube. It was never really used clinically. This is just an example of what that looked like. And then this device was developed again over time. I don't have the name, you can't see here, sorry. But endoscopes developed over the years. This guy, Maximilian Nietzsche, placed a platinum lit tip inside a cavity, and he wrote the quote, "In order to light up the room, one was supposed to carry the lamp inside." So the idea of bringing a light into a cavity was developed by him. Victor de Lespinasse is a urologist who did the first neuroendoscopic procedure going into the choroid plexus using probably a urology scope. The lenses and the scopes we use today were invented by this guy, Harold Hopkins, in 1966, which is that rod lens system. And by having a rod and going along the way in a straight system with lenses, the resolution is very, very high. And as you can see also at the tip, the light goes out to the sides, giving you a much larger radius of view.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.